All right, so this is the first video of a series that I'm gonna review what I think is the most high yield stuff indoors. This video contains about 30 concepts, and I'll keep making these videos until I feel like I run out of ideas. So the first idea I want to talk about, let's zoom in a little bit. Changes in diabetes. Okay, so I want to talk about how diabetes affects vision. In order to understand that, you need to understand the macro and microvascular damage that diabetes does. So we can categorize diabetes damage into two general categories. One of them is osmotic damage. If you remember, this is through sorbitol. The other one is through glycosylation. Okay. Now, glycosylation can lead to a lot of things. You got glomerulonephritis, a lot of things like that. But what we're discussing here today is the two big ones is micro and macrovasculars. So, what is micro an example of? So, first understand that both of these processes happen because uh, proteins on the vasculature are binding to glucose because there is a high concentration of glucose, right? An example of macro first would be arteriosclerosis, which would involve what? Something like atherosclerosis. It would involve hyaline arteriosclerosis, if you remember from cardio, bunch of stuff like that. So big vessels getting a problem. Atherosclerosis is generally the most common one and what you need to know. The micro ones, again, the same type of process happens. If this is the vessel, like a bunch of stuff gets glycosylated, the vessel gets damaged. But it's the same type of pathology, but happens in smaller vessels. And what happens in the eye is twofold. You have cataracts, which happen through osmotic damage. Osmotic damage can also give rise to peripheral nervous system damage. We got diabetes, neuropathy, stuff like that. And the micro can also lead to something called uh, diabetes retinopathy. So that is what, like, when you have like pictures of a retina, the vessels coming out of here. They have like funny stuff, the cotton lesions. They have lesions and stuff like that. It's a representation of microvascular damage of diabetes, which happens through what? It happens through glycosylation. So that's important. I can see them giving us a question. It's like, oh, is it through glycosylation or is it through sorbitol and osmosis and a bunch of random other stuff? The answer would be glycosylation, specifically in the context of uh, vision changes. Unless they're like talking about um, cataracts, which would be due to sorbitol, which is an osmotic type of damage. The second concept I want to talk about is acromegaly. So basically, the problem with acromegaly is that you have high growth hormone because you have high the growth hormone releasing peptide or whatever from the hypothalamus is high, so your pituitary is producing high growth hormone, and then this goes to the liver and leads to production of uh, IGF-1, right? And IGF-1 is what basically what does the job that the growth hormone wants to do. So growth hormone itself doesn't do a lot. What it does is that it increases IGF-1. IGF-1 makes things grow, basically. The other thing I want you guys to understand is the difference between acromegaly and gigantism. These two things are basically the same thing. What goes wrong is that you have whatever tumor in the pituitary that produces growth hormone. But in acromegaly, this happens in a person who's already post puberty, so the person can't grow any longer. So the person usually gets wider. Uh, the bones get wider, but gigantism, it happens in someone who is before puberty, so the person gets super tall. It's the main difference there. Next super important concept. It's going to be 5 questions on this concept in the exam. From I can tell this from my senses, really, but this is something that's going to come up. It's PCOS. for you to understand PCOS is um, the first most important thing is that LH to FSH ratio is high. So you need to understand, your initial point, your what you want to start at is that you have high LH, right? And that leads to what? That leads to high estrogen, and that leads to like longer cycles, right? So estrogen is high, and then your cycles are high, right? And high estrogen also leads to high. Actually, it's not that high estrogen leads to it, but at the same time, I think it's the LH. You have high androgens. Actually, yeah, you have high androgens, and then high androgen get aromatized in peripheral tissue into estrogen, and so androgen into estrogen. What requires here is aromatase, right? And aromatase is found in fat tissue. That's why people with PCOS, if they have high BMIs, uh, this reaction happens more, right? And you get high estrogen, and estrogen messes up with their cycles, right? So that's how you can tie into high BMI into PCOS. Fourth concept, relatively short one, but in Graves' disease, one of the more high yield, diseases we've encountered so far, comes up in every endocrine lecture, every endocrine module. What you see under microscope is scalping of the follicle, and if let's say this is a follicle, these cells, like under histology, these cells are all connected together, and uh, there is like a pink hue in the middle, right? So under, like, when you have scalping, there'll be like these white gaps, like it's a little too thick. I encourage you to go look at a histology slide in case there's a histology questions, but there will be like these gaps here, like this, uh, that are kind of like between the cells and then the what's inside the follicle, right? It's called scalping. The next concept is that in Hashimoto's thyroiditis, we have B cell cancer. It's not really hard to understand. In Hashimoto's thyroiditis, what you see is like follicles under microscopy. So anytime you have a situation where you're stimulating particular type of tissues a lot, you get cancer of that type of tissue. And what's in follicles? B cells. So we get B cell carcinoma. Although this is a point that comes up a little later, but I want to kind of contrast that with what we have in celiac disease. In celiac disease, you have your villi, and then your like these crypts or whatever. You have a crypt like after each villi actually, and then what you have is I'm going to represent it with blue. You have a lot of lymphocytes and these in the tissue. So and also you have blunting of the villi. So your villi are also cut short. In this case, these lymphocytes are T lymphocytes, and you get a T cell type of lymphoma with the celiacs, right? So that's something to have in mind. But in almost all autoimmune conditions, that you're like kind of you have this follicle like appearance. I can't think of anything else off the top of my head, but a lot of things that are autoimmune nature, you get a B cell type of lymphoma. The next point is that the orphan Annie eyes. This is kind of like high yield stuff. You really don't want to mess stuff like this on an exam or on something like this step. Uh, Orphan Annie eyes are for papillary, right? Type of cancer. Also, papillary has soma bodies, like soma bodies. Why? Remember again, papillary has papules. What are soma bodies? They're circular calcifications. So imagine you're looking at this from up here. These cells keep dying and calcifying, kind of like form these calcifications around them. So when you're looking at it from the top, they look like this. Watch out for other names people, whether it's step or exams here, are going to use for soma bodies, right? What, like, they could say microcalcifications, they could say, anything that sounds like soma bodies is soma bodies. If it's like small circular calcifications, any way of describing that, that's soma bodies. um, and remember also we have amyloidosis for medullary carcinoma, and that is because of production of what? That's because of production of calcitonin. So next concept is drugs that cause. Great, I didn't time myself again, so I have no idea how much time I have. Drugs that cause osteoporosis. Remember that corticosteroids cause osteoporosis. They kind of inactivate osteoblasts. Uh, PPIs. So the proton pump inhibitors. The thought behind that is that they're gonna stop, uh, kind of like ionizing calcium in the stomach. So you won't release calcium from food, and you'll have less calcium. Aromatase inhibitors. So one thing that's important for maintaining muscle mass in both sexes is levels of estrogen, right? Estrogen is really important. So that's why a postmenopausal woman will have, so if this is their level of calcium mineralization, they have a drop around like age like 50 or whatever, and let's say this is like 0, this is like 70. They have a drop around this age, whereas for men is like more like there's no sudden drop, and this is because of drop in estrogen. Uh, androgen deprivation therapy. This is for like prostatic cancer when we have GnRH inhibitors. Now these inhibitors can either be like agonists or antagonists. That doesn't matter. What matters is that both those will suppress androgens in a guy with prostate cancer, and that leads to osteoporosis. Last one, malabsorption is not really a drug, but when you have malabsorption, you have lack of vitamin D, right? We have lack of all the lipid soluble vitamins, right? Which is what? Which is vitamin A, vitamin D, vitamin K, and vitamin E, right? So, but D is particularly important in this case because when you have something like celiac disease, let's say, gives you malabsorption, gives you fat malabsorption, or if you have like a pancreas that's not working properly, you're not producing enough enzymes that break down fats, you'll end up with low vitamin D, and osteoporosis is one thing you can see there, right? Uh, Next point is not. I'm not going to explain a lot about it, but basically, when you have bleeding in the context of breast cancer and breast masses, papilloma is the first thing that should come into my mind, unless there's signs of like clear malignancy. So if it's basically it, yeah. So bleeding and if you, papilloma is highly associated with that. I want to talk about pageant disease of the breast and extramammary. So pageant disease of the breast, drawn this so far. Let's imagine this is the breast and this is like the nipple. So there are these ducts that lead to the nipple, right? So in pageant disease of the breast, we have a ductal carcinoma. It's usually in situ, meaning it hasn't invaded yet. And these cells, remember, this is like just a normal epithelium, right? So these cells are like freely moving along this epithelium around here. Just choose a different color. So these cells move from here and they kind of like present themselves to the nipple, and then they can also climb up the epithelium here. So you kind of like see like any description of, oh, like there's a rash or there's a um, like eczema, some sort of lesion, you should make you think of this. And the important, super important point here is that when you see this, the thing you should think about is, the question is most likely going to be about looking like really hard for cancer, or the cancer that's involved. The type is, of course, the ductal carcinoma, and it's in situ. Uh, Now, the extramedullary, this usually happens in vulva, or at least that's the context we've learned. This thing, basically the same idea happens if you have your like basement membrane here, and you have like these bunch of like normal looking cells that as they rise, they become like more and more squamous, right? So the cells are kind of circular at the bottom, and they become more and more squamous as it's normal. You have like kind of like these different looking cells that are kind of interspersed around here, and that's basically extramedullary pageant disease. It happens around the vulva, and so these cells are described as like having atypical nuclei, being big, whatever. But when you get this in a question, the description is going to be like interdispersed, abnormal looking cells within the epidermis. And so the point about this one is that there is no malignancy to look for here. But one thing that's important here, you got to be able to distinguish this uh, from a melanoma. Remember that melanocytes are also randomly interdispersed, and they'll have basically you gotta look for like S something like S100 that's positive in melanoma but negative in these cells. Uh, you gotta look for creatine and there's one PAS. So these cells, remember they're like cells of the vulva, right? Usually they'll have mucus in them. They'll be PAS positive, but melanocytes will be PSA negative. All right, for teratomas, remember that teratomas can be mature or immature. If they're immature, they're more likely to have neuroendocrine tissue, and they can also have some thyroid tissue. They can give you hyperthyroidism like that, and even the mature ones can have squamous, can have skin tissue, right? And that skin tissue lead to squamous cell carcinoma of the skin. So basically, two ways that they can be malignant. They can be mature, and they can have skin squamous cell carcinoma, or they can be immature and have neuroendocrine and be invasive and etc. etc. Next concept is that I want everybody to understand that dysgerminomas and seminomas are the same thing. Seminomas happen in males, dysgerminomas happen in females. They're both the most common germ cell tumors, and they have like a some sort of egg appearance, egg descriptive. It basically like means like cells that look like this. They have like a clear nuclei and they're like round and big, and they have lymphocytes that kind of like lymphocytes that are invading the tumor. They both have good prognosis. Uh, this is going to be super important. Remember this: endometrial carcinoma, risk factor most important one is estrogen. So, but what gives you high estrogen? If you have early menarche, that means a child who's had, let's say, an average girls have their periods around 10. If a child has hers like around, sorry, they have it usually around 14, 15. If a child has hers around like, I don't know, like 10, that's a risk factor. Late menopause, again, why? Because you have estrogen for a longer time. If you are taking, exogenous estrogen, if you have it's sort of some sort of a tumor that's producing estrogen, if you have PCOS, which is I explained before, it's a hyperestrogenic state. Uh, next concept is moles. So these are basically first thing you gotta understand is that it's the dad's fault, right? Dad's fault. That means either the complete one that has 46 chromosomes or the incomplete ones that has the 69 chromosomes. They both these are father chromosomes, right? Sorry, this is the partial, not incomplete. Uh, right? So the complete one, these 46 chromosomes, so they both come from the father. You just gotta know the complete one has the snowstorm appearance. The partial one has partial fetal parts. The complete one is, like, in general, associated with higher invasiveness, higher chance of turning into choriocarcinoma, like just everything. It makes the uterus bigger. It produces more beta HCG. It's just more active, right? The next concept is super important. I think I've seen so many people make this mistake, uh, and that's basically the differentiation between leukoplakia. It's about mouth basically. Leukoplakia and hairy leukoplakia. Hairy leukoplakia happens on the side of the tongue, right? Hairy leukoplakia happens on the side of the tongue. It's not a pre-malignant lesion. It's just there. It doesn't turn into cancer, and the risk factor for it is EVV. Now, leukoplakia, which can turn into erythroplakia, which can turn into squamous cell carcinoma. Risk factor for this is tobacco, and what else? Oh, HPV. Right? These two things are totally different. They just have the same name. This one can turn into cancer. This one happens on the lateral. This is important. It's how to distinguish in a question. Lateral side of the tongue. This happens under the tongue, right? Why does it happen under the tongue? Because usually, like you chew when you chew tobacco, it's not even under; it's in the cheeks. Because when I mean, no one does it anymore. But when they used to chew chew tobacco, that's where they like put it in their mouth. All right. This one I talked about it. Celiac histology. You got villi that are not as high. That villi that are blunted, and you got a lot of lymphocytes. A lot of lymphocytes, and it will give you a higher chance of developing a T cell lymphocyte. Whipple disease happens in old guys. It's because of a bacteria. It's like Whipple something. Histology. It looks like you know there is these like lacteals in the small intestine that take all the fat products because you can't just like put chylomicrons in the blood. They take them to the liver, and in this disease, there'll be macrophages all over this place that have these Whipple organism in them, and they will block the lacteals, and you get malabsorption, right? So malabsorption, that's how it's related to GI system. You get malabsorption from this. And when you do staining, these organisms are PAS positive. Oh, it's too big. Uh, they're PAS positive, so it will give you a description of PAS positive organisms in the macrophages in the villi. PAS, periodic acid shift, is labels basically mucus and glycogen. Ulcerative colitis. Okay, I mean we all know about ulcerative colitis and Crohn's by now, but fast review of both concepts. What is ulcerative colitis associated with? It's primary sclerosing cholangitis that happens more in guys. That's P-ANCA, right? Crohn's also has an antibody. I don't think it's important. It's a ASCA, I think. I don't know what it stands for. This might even be wrong, but uh, I don't even think we went over it in the lecture. Now, ulcerative colitis starts at the rectum, and so let's say this is like a small intestine type of thing, right? And this is so ulcerative colitis starts here, makes all the way up here, and it stops at cecum. Stops at the end, and we have like the small intestine here that goes and like does whatever small intestine does. Uh, so it's important to know Crohn's always starts here, works its way up until this is as far as it goes, right? But different story sorry, that was ulcerative colitis. Uh, with Crohn's, it can be anywhere. It usually spares the anus, right? Um, and it happens in terminal ileum a lot. So because it happens in terminal ileum, it gives you a bunch of things. One thing is that it causes lower reabsorption of bile salts, right? So your bile salts go down. What does that lead to when you have low bile salts? You can't kind of solubilize cholesterol in your cholecyst in your basically gallbladder, so you get cholesterol stones. The other thing that happens is that you absorb a lot of oxalate, so you'll start making what you start making and oxalate stones in your kidneys, and you have I'm gonna write the next one here. You have malabsorption, right? Also remember Crohn's is kind of is a granulomatous inflammation. It's really important, and it's obviously non-caseating because it's not due to TB or a fungi or an infection. So non-caseating inflammations. You got cobblestoning with Crohn's. You got pseudo, polyp, something like that with ulcerative colitis. Uh, I mean, a lot of things will give out the answer in a question about these two. So let's remember that small cell lung cancer will produce ADH, and squamous cell um, will lead to hypercalcemia. So squamous cell produces this hormone called uh, what is it called? PTH like hormone or like peptide, right? So it's not PTH, but it's PTH like peptide has a similar effect, and that leads to the intestine taking more calcium than it needs to. It leads to the nephrons taking up all the calcium. It leads to the bone releasing calcium. So all it increases calcium, right? But how do you see increased calcium? It's got an acronym. It's like um, stones because you make kidney stones. Moans because I think it's with GI problems because it hurts, or it's like you psychotic. Uh, I don't know the acronym, but basically you make stones, but and uh, get bone pain, you get GI pain, and you have like psychiatric things because of hypercalcemia. Uh, Now the other thing I want to talk about is SID ADH. You have high ADH, right? Antidiuretic hormone. So you're not decreasing, you're not losing any water. What happens um, when that happens? Then, if you're not losing any free water, you have high volume, right? When you have high volume, I think that inhibits your like renin stuff, and thus you'll end up losing a lot of sodium. So what it leads to is that you'll go down a lot on sodium, and that's what really gets people or like gets the patients. Low sodium is one of the important things. Uh, so you have high volume, uh, low sodium, and high volume, right? You don't know if you don't fix that. It kind of sounds like also just like a random connection, but remember that plasmodium, mycoplasma pneumonia will also give you hyponatremia. Um, yeah. So what do you give a person that has high ADH? You can give them Vaptans, or you can give them demiclocycline or demiclocycline. It's a tetracycline that's only used for this purpose. Mallory-Weiss syndrome is basically for people who puke a lot, who kind of like induce vomiting, and there's a bunch of risk factors. One of them is if you have GERD. The other one is that if you have bulimia, um, if you have a hernia around the hiatal hernia, these all can be risk factors. But the cause of it is the physical stress from the vomiting action. You got Hirschsprung disease, which is basically when you don't have like gut neural tissue towards the end of your GI tract, and it's because of lack of migration of neurocrest cells. And remember, it's because of Down syndrome that this happens. And if you want to summarize Down syndrome, is like a big part of it can be summarized as neurocrest cells lose the ability to migrate as much. So you have this problem here, but you also have a lot of like the cardiac problems. Is because if you remember in cardiac in biology, a lot of these neurocrest cells will have to migrate to different places to like uh, help the complex structure develop. So when you don't have when you're having problems with migration of neurocrystals, you have problems with the heart. You also have problems with neurocrystals not moving to the end of the GI, and having Hirschsprung disease. One sign that Hirschsprung disease has is called I don't know what it's called, but basically when you do a rectal check, there's like feces scored out, and that's can be seen. That can be used as a sign. Okay, I'll do the rest of it in part two.